Assalamu alaikum wa rahmatullahi wa barakatuh. We will discuss today the scrotum from the surgical point of view. Dr. Mohammad Algazar, lecturer of general surgery. At first, we must know the embryology of the testis and the surgical anatomy. Actually, we have 5 main topics in the scrotum and testis. 2 of them were clinical cases in the last year exam, and the 3 other cases were important cases in your clinical life, and they considered as emergency cases, which must be diagnosed as early as possible. The 2 clinical cases is the varicocele, which is common in the last year clinical exam, and hydrocele. So we must know the varicocele and the hydrocele very good, because they are the clinical cases in the last year exam. And we have other 3 cases which is important in clinical practice. Actually, the testicular torsion, which is a very important and emergent topic, must be diagnosed as early as possible, and the undescended testis, which is also an important topic in the pediatric surgery, and lastly the testicular cancer. So we must stress on these 5 topics in this lecture. To discuss the undescended testis, which is an embryological disease, defect in the embryology of the we must know the embryology of the testis at first. As we see in this picture, the testis is raised from the genital ridge, which is derived from the mesoderm in close relation to the mesonephric tubules. At first, the genital ridge in close relation to the mesonephric tubules, the genital ridge forming the testis. The caudal part of the paramesonephric tubules degenerated, and this is the cranial part of the genital ridge, and the cranial part is degenerated, and the caudal part forming what's called the gubernaculum. A gubernaculum is the attachment of the testis which pull it downwards. The lower pole, which is called the gubernaculum of the mesonephric paramesonephric duct, which is degenerated, as we see in this picture. The cranial part is degenerated, and the lower part forming the gubernaculum, which is connected to the future scrotum, which is called the genital swelling, and the middle part forming the testis. The middle part of the genital ridge forming the testis. It's a cranial part degenerated, and its caudal part forming the gubernaculum, which take the testis downwards towards the future scrotum. As we see in the second picture, the descent of the testis begin in the 7th intrauterine month, passing through the inguinal canal. The testis at first is behind the peritoneum in relation to the mesonephric tubules, in relation to the kidney. So it's descended downwards by the gubernaculum to the inguinal canal, through the internal ring, then through the superficial ring. It reaches the superficial ring at the 8th month and reaches the scrotum in the 9th month. At the end of the pregnancy, it lays in the bottom of the scrotum. During the descent of the testis, it takes part from the peritoneum, which is called the processus vaginalis, fold from the peritoneum, which is called the processus vaginalis, which cover the testis by a serosal covering called the tunica vaginalis, and the processus vaginalis obliterates. If it persists, it leads to formation of hernia or formation of hydrocele. Why is the testis descended downwards from the thoracic cavity behind the coelomic cavity in relation to the kidney, why the testis descend to the scrotum. At first, the most important factor is the gubernaculum. The gubernaculum, the caudal part of the genital ridge. The caudal part of the genital ridge pull the testis downwards, and the maternal beta HCG reaches the fetus, leads to engorgement of the testis and enlargement of the testis. It descends by its weight. Elongation of the body of the embryo has a little factor, and increase in intrauterine pressure squeezes the testis to the scrotum. But actually we have two main factors: the gubernaculum, which is the most important factor in the descent of the testis, and the maternal HCG, which leads to enlargement of the testis and its engorgement. We use beta HCG in undescended testis in early stages in the first 3 months. Injection of the beta HCG to the baby with in the first 3 months may help the descent of the testis before we proceed to surgery. يبقى again, the testis is derived from the genital ridge. From which part of the genital ridge? What's the genital ridge? It's the genital ridge is related to the mesonephric tubules. Mesonephric tubules behind the coelomic cavity. The genital ridge is formed of 3 parts: cranial part, which is upper part and it's degenerated; middle part forms the testis; and the lower part of the genital ridge forms the gubernaculum. The gubernaculum pulls the testis downwards till reaching the scrotum. When the testis begin to descend in the 7th month, the testis begins to descend to the scrotum. It reaches the superficial ring at the 8th month, reaching the scrotum in the 9th intrauterine month. In the late pregnancy, it lays in the bottom of the scrotum. What are the factors help of descending of the testis? The most important factor is the gubernaculum, followed by the maternal HCG, which increases the testis weight, leads to its engorgement and descent by the weight. The other increase intra-abdominal pressure and the elongation of the fetal, the body of the embryo, leading to descent of the testis. So the defect in the embryology here is undescended testis, which is an important topic. We'll discuss it now, inshallah. What's the anatomy of the testis? The testis is 2 by 1 by 1 inches. It has true capsule, which is called the tunica albugini. Albugini meaning white, tunica meaning cover, يبقى white cover of the testis. Then, which is formed from the fibrous tissue. Then it's surrounded by the 2 layers of the tunica vaginalis. What's the tunica vaginalis? It's a part from the processus vaginalis. What's the processus vaginalis? It's a part from the peritoneum. So the tunica vaginalis covers the testis by 2 layers, visceral and parietal layers. Visceral, which is related to the scrotum itself, and parietal layer, which is related to the outer side. The testis has 2 borders, anterior and posterior, 2 surfaces, medial and lateral, and 2 pools, upper and lower pool. 2 borders, anterior and posterior, 2 surfaces, medial and lateral, and 2 pools, upper and lower. A change in this directions of the testis is called inversion of the testis. Inversion of the testis, the anterior and posterior borders may not be anterior and posterior, medial and lateral. Medial and lateral may be anterior and posterior. Upper pool may be inverted to be the lower pool, and this cause what's called torsion of the testis. Inversion, one of the causes of testicular torsion. The interior of the testis, as we see in this picture, is formed from the seminiferous tubules. Testis is divided into compartments. These compartments contains the seminiferous tubules. The seminiferous tubules containing the cells which form the testosterone, and cells which form the germ cells, which form the sperms. The seminiferous tubules anastomosis with each other in the posterior border of the testis to form what's called rete testis. Rete testis from which about 15 to 20 vasa efferentia, which join each other to form the epididymis. Epididymis is formed from head, body, and the tail. The tail is extended to form the vas deferens. As we see in this picture, the vas deferens reached the prostate and then the urethra to secrete the semen inside the urethra. The testis is formed from the seminiferous tubules. Seminiferous tubules coalesce with each other, unite with each other to form the rete testis. The rete testis forming what's called the vasa efferentia, small tubules. These small tubules collected with each other to form the epididymis. Epididymis is formed from head and body and tail, and the tail continued as the vas deferens. The vas deferens has a long course to descend reaching the prostate and to secrete the semen into the urethra. What's the blood supply of the testis? The testicular artery, which is the main artery of the testis, is formed from the abdominal aorta at the level of L2. Cremasteric artery from the inferior epigastric artery of the vas from the inferior vesicle. Scrotal arteries from the internal duodenum. The testicular artery is from the abdominal aorta. Cremasteric artery is from inferior epigastric artery, which is a branch from the external iliac. Artery of the vas from the inferior vesical artery, which is branch of the internal duodenum. Scrotal arteries, which is a branch from the internal duodenum, which is a branch from the internal iliac artery. The venous drainage of the testis, which is important. Why it's important? Because disease affects the venous drainage of the testis, leading to varicocele. We must know that the venous drainage of the testis is about 4 to 6 veins. 4 to 6 veins is called the Bambini-form plexus of veins. These veins reach the inguinal canal. After leaving the inguinal canal, they become 1 to 2 testicular veins, which drain directly into the IVC on the right side and directly to the left renal vein on the left side. Left renal vein to the left side, and this is an important point. So the right testis drain into the IVC, inferior vena cava, and the left testis drain into the left renal vein. Right to the IVC, left to the left renal. And the cremasteric veins, which anastomose with Bambini-form plexus and drain into the inferior epigastric veins. As the cremasteric artery raised from the inferior epigastric artery, the cremasteric veins drain into the inferior epigastric veins. Sympathetic supply is from T10 to T12, run with the testicular arteries. The lymphatic drainage is to the para-aortic lymph nodes. As we know that in the abdomen, and the testis is an embryologically abdominal organ. So the abdominal organs drain into the lymph nodes which accompanying the arteries. Unlike the other parts of the body, the lymph nodes accompanying the veins, like the cervical lymph nodes, which accompanying the internal jugular vein, and the axillary lymph nodes accompanying the axillary vein, the inguinal lymph nodes accompanying the femoral vein, while in the abdomen, the venous drainage accompanying the arteries, not the veins. So the lymphatic drainage of the testis is to para-aortic lymph nodes accompanying the arteries to the testis. Testicular artery rising from the para-aortic lymph nodes, and this is important to the cancer testis metastasis to the para-aortic lymph node. So when I want to eradicate the cancer testis, I must treat the para-aortic lymph nodes, remove or by radiotherapy. And maybe to the internal iliac lymph nodes, as the internal iliac artery give to the inferior vesicle and the internal duodenum. What are the layers of the scrotum? The scrotum has 7 layers. 7 layers. The first is the skin. And under the skin of the scrotum, the dartus muscle. The dartus muscle in the superficial fascia. Then external spermatic fascia, criomastric muscle or fascia, which is derived from the internal oblique muscle, and the internal spermatic fascia, and then the parietal layer of the tunica vaginalis, and then the visceral layer of the tunica vaginalis. What's the importance of the layers of the scrotum? And during the surgery of hydrocele, or during the surgery which requires a scrotal approach. Scrotal approach, you must open the layers of the scrotum. The layers of the scrotum are 7 layers: skin, dartus muscle, external spermatic fascia, criomastric muscle and fascia, internal spermatic fascia, and 2 layers of the tunica vaginalis, parietal, and then the visceral layer, which is related to the tunica albuginea of the testis. This is the surgical anatomy and embryology of the testis, and we will proceed to the congenital anomalies of the testis. The most important is the Maldescended testis. As we said that the testis descend from the abdominal cavity, retroperitoneal, to the scrotum, and begin at the 7th month, then the 8th month it reaches superficial ring, lastly in the 9th month it reaching the scrotum. If the testis has arrested descent and not reaching the scrotum, it's called undescended testis. If the testis descended to another site rather than the scrotum, like the femoral canal, may descend to the femoral canal, or maybe transverse in the scrotum. It's called ectopic testis. But we have 2 types of Maldescended testis. Maldescended testis, we have arrested testis or undescended testis, which descend its normal pathway and arrested at the middle of this pathway. Ectopic testis, the testis deviated from the normal pathway and descend to another site, not to the scrotum, like the femoral canal, for example. طيب, what are the causes of Maldescended testis? We have 2 main factors which leading to descent of the testis, as we said in the embryology: the caberniculum and the gonadotrophin hormone. So deficiency of the gonadotrophin hormones, beta HCG, leading to Maldescended testis. And the second is abnormality of the caberniculum. We said in the embryology, the 2 factors which affect the descent of the testis is the beta HCG, maternal beta HCG, and the caberniculum. So abnormalities in these 2 factors leading to Maldescended testis. Also anatomical abnormalities like adhesions, retroperitoneal adhesions, or in the inguinal canal, and short testicular vessels, narrow inguinal rings. But the most common is deficiency of gonadotrophins and abnormality of the caberniculum. Their causes is adhesions, short testicular vessels, and narrow inguinal rings. What's the problem of the Maldescended testis? Why it's an important topic? What's the problem with undescended testis? We know that Allah subhanahu wa ta'ala leading to descent of the testis to the scrotum because the temperature in the scrotum is lower than the temperature in the abdomen by ½ degree. So if the testis lay in the abdomen, the temperature inside the abdomen is higher than the scrotum. This higher temperature leading to atrophy of the testis, which affects the spermatogenesis. And if it's bilateral undescended testis, this leads to sterility of the patient. And it's also leading to tumors formation. Higher temperature leading to increased tendency of the scrotum to form malignancies. This is the most two important complications of the undescended testis. The first is atrophy of the testis from the higher temperature in the abdomen, leading to defect in the spermatogenesis, and if it's bilateral, leading to sterility. The second is tumorigenesis. It's leading to formation of the tumors. Also, the undescended testes have an increased incidence to form a torsion of the undescended testis, leading to loss of the testis also. Psychological troubles and feeling sexual inferiority. Trauma more liable for trauma in the abdomen, is more liable for trauma, and may be associated with interstitial hernia, which is due to non-closure of the processus vaginalis. Interstitial hernia in 80% of cases. We have two main complications with undescended testis: atrophy of the testis and tumorigenesis. Tendency to malignancy is, if not approached by the surgical resection. The testis may arrested in the abdomen, so it's called intra-abdominal. In the inguinal canal, it's called inguinal testis. In the subinguinal canal, higher in the scrotum, it's called subinguinal. At first, what's the presentation of the undescended testis? The presentation of the undescended testis is feeling that the scrotum is empty. One side of the scrotum is empty and loss of the wrinkles of the skin. And the skin of this compartment become atrophied. The undescended testis, if it's inguinal or subinguinal, may be palpable. The pediatrics doctor must examine the baby at first when he delivered, and see if the testis is undescended or not, to avoid its complications. Because if the testis is left more than 1 year, it leads to atrophy and no return from the atrophy of the testis. What are the investigations can be done to diagnose the undescended testis? Ultrasonography to detect the site of the testis, it's inguinal or intra-abdominal. Ultrasonography. If it's not detected in the inguinal canal, we can do MRI, magnetic resonance imaging, to detect its intra-abdominal. Laparoscopy may replace the MRI. Laparoscopy, entering a camera inside the abdomen and see the abdomen and the site of the testis to detect its site. How to differentiate inguinal arrested testis from the inguinal ectopic testis? In the inguinal arrested testis, the cord is lateral to the testis, while in the ectopic, it's medial to the testis. The testis can be pushed laterally, but not medially. While in the ectopic testis, the testis pushed medially, not laterally. The testis become more apparent with straining, while the testis become more apparent on straining. In the ectopic testis, with straining, the testis become more apparent. What's the treatment of the undescended testis? At first, we said the defect is in the beta HCG. In the first 3 months, we can give in the first 6 months, we can give the baby chorionic gonadotrophin, HCG hormone, 100 international units per kg twice weekly for 5 weeks. The testis may descend. If the testis is not descending, we can proceed to surgery. The time of surgery is very important. We must do surgery before the age of 1 year. Because after the age of 1 year, the testis become atrophied, and if we descend it after 1 year, it will not work. So the testis become atrophied after the age of 1 year. We must descend the testis before the age of 1 year. The time of surgery between the 6 months and 1 year of the patient. What's the type of surgery? It's called the Dart's pouch. we can remember the layers of the scrotum, skin, and then dartos muscle. We open the inguinal canal and then send the testis from the abdomen or from the inguinal canal, and we remove the adhesions around the spermatic cord of the testis, spermatic cord, and we descend the testis to the scrotum. We must fix it. We must fix the testis to avoid its returning again to the inguinal canal or into the intra-abdominal. So we must fix it. We fix it by the dartos pouch. Dartos pouch between the skin and the dartos muscle, and fix the scrota, the testis, to the scrotal skin by stitches. This is called dartos operation. If you have a problem like short vessels of the testis, we can do what's called Flower-Stephens operation. Flower-Stephens operation, division of the vessels of the testis, and then we put them into anastomosis with the testicular artery and the artery of the vas if it's intact. This is microvascular technique, division of the testicular artery and reanastomosis with the inferior epigastric artery. We can do orchidectomy in the cases of atrophied testis to avoid tumorogenesis. Again, the undescended testis. Undescended testis is caused by two main causes: deficiency of HCG, gonadotropins, and abnormalities on the gubernaculum. We have undescended testis or ectopic testis. The undescended testis may be intra-abdominal, inguinal, subinguinal. We have two main complications: atrophy of the testis, defect in the spermatogenesis, and tumorogenesis. How to diagnose the undescended testis? Empty scrotal compartment which containing the testis, and skin is atrophied, loss of wrinkles. What's the investigation of choice? Ultrasonography to detect the inguinal testis or intra-abdominal testis. If not detected by ultrasonography, you can proceed to MRI. If not detected by the MRI, we can proceed to the laparoscopy. What's the treatment of choice for the undescended testis? In the first 6 months, if it's inguinal testis, we can give the patient gonadotropin 100 international units per kg twice weekly for 5 weeks. If it's not descend, we can do the dartos pouch operation, pouch between the skin and the dartos muscle. We fix the testis to this pouch by stitches. If the testis is atrophied, we can do orchidectomy. Thank you. This is the undescended testis. We have a topic which is called retractile testis. Some babies has a retractile testis, not undescended testis, and the testis descend to the scrotum and ascend again, descend and ascend. We can do what's called the shear test, putting the baby on the shear, and we do flexion of the both knees. The testis will descend. The testis will descend to the scrotum. This is retractile testis. This is called shear test. Retractile testis requires no treatment if not affect the size of the testis. This is the first important topic in the scrotum and testis. The second important topic is testicular torsion. Testicular torsion is caused. What's the testicular torsion? What's the meaning of torsion? Torsion meaning twisting. Twisting of the testis on its blood supply, with its long axis of its blood supply. Twist of the blood supply of the testis leads to its strangulation, gangrene of the testis. As we see in this picture, the testis become plaque, and we see the normal tissue above, which is pink. This is the testis, which is abnormal because due to cutting of the blood supply of the testis. It's a surgical emergency. If the torsion of the testis not diagnosed and treated within 6 hours, from the torsion, this will lead to orchidectomy and loss of the testis. So the testicular torsion is a surgical emergency. We must diagnose it as early as possible, and we must treat it as early as possible before 6 hours to avoid the loss of the testis. So, what's the predisposing factors of testicular torsion? We say that the inversion. Inversion are changes of the abnormal position of the testis in the scrotum. We have two types of inversion mainly, anterior inversion and polar inversion. The anterior inversion, the epididymis become anterior. The epididymis normally is posterior. While the polar inversion, which the upper pole of the testis and the head of the epididymis lays inferiorly. We have superior inversion and lateral inversion. But the most common cause of the testicular torsion is inversion of the testis. All types of inversion are the commonest predisposing factors, especially superior inversion. The second is undescended testis. We said what's on the complications of undescended testis is testicular torsion. And what's called the Clipper in Appel syndrome. Clipper in Appel syndrome, we say the covering of the testis, the tunica albuginea and the tunica vaginalis. If the tunica albuginea is redundant and the testis inside clipper in the pill, if the tunica albuginea and the tunica vaginalis are redundant, if the tunica vaginalis is redundant and the testis become like a pill in the clipper, like a pill in the clipper, this leads to movement of the testis and they may rotate around the vessels, leading to testicular torsion. We have three causes of testicular torsion: inversion of the testis, Clipper in Appel syndrome, arrested and ectopic testis. What are the precipitating factors? Minor trauma may precipitate the testicular torsion, straining, lifting heavy objects, during surgical, during intercourse, and it's thought that the spirally arranged cremastric muscle begins as a torsion, together with the pulsations of the twisted testicular artery, will complete and maintain the torsion. What's the pathology of the testicular torsion? The lower pole of the testis rotates in a direction away from the midline, clockwise on the right and anti-clockwise in the left. The testis become congested and edematous due to obstruction of the veins at first. What's the complications of the testicular torsion? Infarction of the testis, gangrene, and sterility. Why sterility? If the torsion is in one side, it leads to sterility also, because the infarcted testis leads to destruction of the testicular blood barrier, leading to formation of antibodies against the testicular tissue. The antibodies, these antibodies attack the other testis, the other normal testis, leading to sterility, secondary hydrocele, and shock from the pain. The testicular torsion is common in adolescence, which is the commonest, and the infancy, the second common. What's the symptoms and signs of testicular torsion? The testicular torsion is called acute scrotum. What's the acute scrotum? Like the acute abdomen, acute scrotal pain. We have two causes of acute scrotum. Two main causes of acute scrotal pain must be diagnosed: testicular torsion and acute epididymo-orchitis. We must differentiate between testicular torsion and acute epididymo-orchitis. At first, sudden, severe, agonizing pain in the scrotum, which is radiating to the lower abdomen, is testicular torsion until proved otherwise. Sudden, severe, agonizing pain in the scrotum radiating to the lower abdomen with vomiting, this is an testicular torsion until proved otherwise. The torsion in completely descended testis, the testis is tender, swollen, scrotum is red and edematous, and we can feel the twist in the spermatic cord if we can. In the arrested testis, the tender inguinal swelling stimulates strangulated hernia or acute appendicitis on the right side, but characteristically the scrotum is empty. A torsion in the arrested testis like the strangulated hernia. Again, acute scrotal pain is testicular torsion until proved otherwise. The two main causes of acute scrotum is testicular torsion and acute epididymo-orchitis. So the acute epididymo-orchitis is the main investigation, the main differential diagnosis for the testicular torsion. What is the investigation of a choice in the testicular torsion is duplex ultrasound. Duplex ultrasound sees the blood vessels and sees the flow of the blood supply inside these blood vessels and see that the twisted blood supply, so this can detect the testicular torsion. The treatment is urgent surgical exploration of the scrotum and untwist the testis. Untwist the testis. If the duplex is not present and we suspect the patient has testicular torsion, we must do exploration of the scrotum also to avoid the medical litigation. As we see in this picture, the testicular torsion is the twisting of the testis and the spermatic cord, results in ischemia, acute pain, and the swelling of the scrotum, as we see in the picture. The investigation of choice is Doppler ultrasound, demonstrate decreased blood flow, and the testicular torsion is a surgical emergency that requires intervention within 6 hours. This is an informative illustration of the testicular torsion. 4 sentences that describe the testicular torsion. Testicular torsion is the twisting of the testis and the spermatic cord, results in ischemia. It's presented by acute pain and swelling, diagnosed by Doppler ultrasound, demonstrate decreased blood flow, and the surgical emergency treatment of the testicular torsion within 6 hours. Doesn't forget this illustration. What's the differential diagnosis of testicular torsion? Acute epididymo-orchitis is the main differential diagnosis of testicular torsion. The epididymo-orchitis onset is gradually to rapidly progressive, but the testicular torsion is sudden. The site of the epididymo-orchitis pain is the epididymis, testis, and the cord, while the testicular torsion is the testis and the cord. Urinary symptoms may be often more in the epididymo-orchitis, while less in the testicular torsion. Pain is severe in the testicular torsion, mild to severe in the epididymo-orchitis. Urine analysis may show leukocytes, blood nitrates in the epididymo-orchitis, leukocytes mainly, but in testicular torsion it's normal. Ultrasonic features, ultrasound, not duplex ultrasound. Ultrasound, increased flow, hyperemia. Testicular torsion, not diagnostic, may show impaired flow. Treatment, antibiotics of epididymo-orchitis. Testicular torsion is surgical treatment. We see in this table, there is no clinical differentiation between the epididymo-orchitis and testicular torsion. We can't differentiate clinically. Actually, in practice, we can differentiate clinically by epididymo-orchitis from the testicular torsion. So, duplex ultrasound is a must in any acute scrotal pain. Testicular torsion or epididymo-orchitis, duplex ultrasound can diagnose it. Gradual onset and rapidly progressive course in the epididymo-orchitis can differentiate, but the two present in adolescence, young age population. So we must differentiate between epididymo-orchitis and testicular torsion by duplex ultrasound. Again, acute scrotal pain must be diagnosed by duplex ultrasound. Thank you.